Welcome to the first of our four-part series. We're going to have a lot of great topics this month. This evening's presentation is going to be specifically around player welfare for women in rugby. So we have a fantastic panel of presenters tonight. What we're going to cover is some really good topics, particularly around injuries that are more prevalent in females, mental health in the rugby space, and then how to support player welfare in your communities, and some really good resources to take away from that. So without further ado, I'd like to introduce our panelists. So we have three amazing presenters. We have Dr. Dalia Jordan-Brown, who will be presenting first. She is an OBGYN in Trinidad and Tobago, and a former national team player as well for Trinidad and Tobago. And Dalia has been working in the rugby space since 2006. She's going to be addressing the injury information as it relates to females in rugby.
Hi, everyone. Hi, so I'm Dalia Jordan-Brown. As Erin said, I'm a part of Trinidad and Tobago's Rugby Union. I've been involved since 2006, and I've kind of transitioned from on the field to off the field, mainly with player welfare. And well, today I'm going to go through injuries as it relates to women in rugby. So I'm just going to start my slideshow. All right. So basically, first I'm going to just go through the different anatomical features that could predispose women to certain injuries, and then talk about some of those injuries. And then we'll talk about menstrual disorders that can affect performance. So to start off, we have women tend to have shorter and smaller limbs, but relative to the body length, which actually works in our favor in terms of that it lowers your center of gravity and it can improve balance. We also have a wider pelvis and what we call knee valgus, which is basically an inward turning of the knees, which in Trinidad we tend to call knock knee, yeah, but it's just basically an exaggeration of that inward turning of the knee. And this can predispose women to knee injuries as well. We tend to have less muscle mass, meaning that the bulk is a little leaner. It doesn't mean that the quality of muscle is different. The same things that would affect men in terms of quality of muscle would be the same with women, but it can, but this does work in our favor in terms of flexibility. So women tend to have more flexibility than men, but when you combine that with the increased joint laxity and ligaments, it can predispose us to injuries. Right? Laxity just means the joints tend to be a lot looser, and you can have hyperextension, which means that the joint tends to go in a direction that it shouldn't probably go. So from one of the injuries that are most common are injuries to the anterior cruciate ligament, or the ACL, right? As you can see from the picture, it's the red ligament that you see. It forms a little crisscross with the posterior ligament between the femur, which is the thigh bone, and the tibia, which is the shin bone. And these injuries can be from either partial or complete tears or strains, and it's 2 to 6 times more high in women than in men, right? It's commonly, the common presentation is a sudden stop or change in direction. There may be an incorrect landing, or due to direct contact or collision.
Dalia, can you just pop down to the next slide? I think we just couldn't see the picture.
Oh, it's supposed to be, is that, no. Are you all seeing it?
No, not yet.
Sorry.
That's okay. Maybe it just needs to catch up.
I don't know, it should be here. I'm seeing it. Hold on. Give me 1 second. Let me see if I can stop share. And let me share again and see if we're good from there. Yeah? Oh no?
Yeah, perfect.
Yeah? Okay, great. Sorry about that. Right. So as I was saying, it's the red ligament that you can see there. That's the ACL ligament. That it's between the femur bone, which is the thigh bone, and the tibia, which is the shin bone. And that I was saying before, the usual presentation is either sudden stop or change of direction, an incorrect landing, or from direct contact or collision. And usually may hear a pop and you have a sudden loss of power in the knee. And it tends to, and why it's more common in women is that the same anatomical factors that I was bringing up before. So the wider pelvis, the knee valgus, also women tend to land a little more flat-footed than men, and it can predispose, so the knee absorbs most of the shock. So ACL, that's one of the reasons why it's 2 to 6 times more high in women than in men. Generally, in terms of prevention for ACL tears, besides the usual increasing like muscle and core strength, you'd also advise in terms of certain drills like landing techniques, agility, balance, speed. Those help prevent ACL injuries. All right. Sorry. The next thing is stress fractures. Now, stress fractures are different from an acute fracture, which you get a force and it will cause the immediate break, while a stress fracture is a cumulative repetitive forces on the bone, which eventually causes it to break, right? And when it finally breaks, it may not have even been a very big force, but because of the over time repeated trauma to the bone, it will eventually break, right? It usually affects with women lower extremities like the tibia, which is the shin bone, the femoral neck, which is the neck of the thigh bone, the bones in the feet, and the pelvis. Patellofemoral pain syndrome is 20 times more likely in men as opposed to 7% in men. In women as opposed to 7% in men. It generally presents as pain behind the patella or the kneecap, and it's usually worsened with activity. You tend to see it with overuse or malalignment of the knee, and generally treated with physiotherapy. Right. Now, breast injuries are actually common but widely underreported in women and female athletes. There was a study that checked, that did a survey between 182 female athletes, and 36% of them did have a breast injury, but only 10% of them reported it. They found that different reasons why it's so underreported is either due to embarrassment or just being uncomfortable telling a physio or coach, especially if they're a male physio or coach, about the injury, and also feeling like, the injury is not that big a deal or not that important to even say or bring up. Yeah. The different injuries are contusions, you have hematomas, bruising, edema, which is like swelling, and pain. And it can be caused by either direct contact or abrasive bras or uniforms. It tends to be more common in, well, of course, women who play contact sports, women with a higher BMI or larger breast size. Now, relative energy deficiency in sport, or REDS, or some may know it more as the female athlete triad, right? This is basically a chronic low energy availability, which leads to disruption of physiological symptoms. So the chronic low energy availability can be caused by either poor diet or an eating disorder, or from over exercise or activity. But basically, the amount of calories in is way less than the amount you exert, and then there's an imbalance which leads to low energy availability. And this can affect multiple systems. So it can affect your metabolism, bone health, the reproductive system, your immunity, as well as your cardiovascular system. In terms of reproductive health, what tends to happen is that the low energy availability can cause changes in the production of your hormones, which can lead to disruption in the menstrual cycle. So women can present with either no period at all, or periods that come very far apart. And for younger girls who've never seen a period, they may have what we call delayed menarche, which just means that they don't see a period at all. And one of the hormones that get disrupted is estrogen, and estrogen is very important for proper bone health and the formation of proper bones. And that low estrogen can lead to long-term decrease in your bone mass density, right? The decrease in the bone mass density then leads to things like stress fractures, which we discussed before, osteoporosis. And depending on the extent of the disease and how long it's been going on for, it can be irreversible. And especially for younger girls, especially in now starting playing in the younger leagues, who are now going through puberty, which is at the peak time for most bone mass development. If those changes start to occur from then, they tend to be more irreversible than if it occurs later on in life. Right. And lastly, menstrual disorders. So in this case, we're talking about things that sport doesn't necessarily cause the issue, but if you have these issues, it can affect your performance in sport. So a lot of women have, one of the things that can affect is uterine fibroids. So basically, fibroids is a benign tumor that grows within the womb, which can lead to very heavy, very prolonged, and very painful periods. And it can affect players at the point in time when they do have their period and they may have to play a game or have training, or it can have long-term effects in terms of players with these tend to have very low blood counts or anemia, which can lead to long-term effects like very excessive tiredness, fatigue, headaches, palpitation, dizziness, right? And obviously it can affect not just their performance on the field, but off the field as well. Endometriosis is another one. This is basically when the lining of the womb, it gets implanted outside of the womb, and it can lead to very painful periods. And the pain can be so severe that they may not be able to function at the point in time when it's occurring, but it can also lead to chronic pelvic pain, which can cause them to be on pain medication, not just high dose medication, but very strong medications, which may have a lot of side effects. Like some of them could make you very drowsy, sleepy, and it can affect your performance on the field. So if you don't take the meds and you can't even reach the field, but then when you take the medications and you reach on the field, you can't perform as you would normally. Lastly, polycystic ovaries. It's basically a combination of multiple cysts on the ovaries, and you tend to have a higher level of, a hormonal imbalance, where you have a higher level of the hormone and androgen hormones like testosterone, which can lead to what we call an ovulatory period. So you don't really ovulate, and you have very irregular periods. Sometimes you may have long spaces where you don't have a period at all. And then when you do get a period, it may last for not just days, but weeks. And it can have the same effect as uterine fibroids or even endometriosis on your performance. Now, the issues with these disorders and performance in sports is that a lot of people don't realize, they're not as sympathetic to issues dealing with the menstrual cycle and menstrual disorders. A lot of people compare their experience to yours, and when you say, so if you're not performing as you usually do, and they ask, they're like, oh, it's just bear it, like get over it. But your experience may not be theirs, and it can affect your, not just in terms of your performance on the field, but generally lifestyle. So there's a lot of judgment that goes along with it, as well as it's been known to, especially with younger girls now starting with the sport, they may have a higher dropout rate because they can't function now with all these new changes, right? And generally, we would advise, of course, that you see a gynecologist and you get assessed and diagnosed, and they get a treatment plan that's specific for you and your needs, and not just your needs in terms of lifestyle, but in terms of sports and what you want to do and how you want to function. So that's it for me.
Thank you, Dalia. We do have one question, which I think is right up your alley. So the question is, can you address return to play or return to, let's say, activity, refereeing or playing after delivering a baby?
Okay, good. I was hoping somebody would ask it. So the thing is, it would depend on different factors. One, the type of delivery, in terms of if you had a normal vaginal delivery as opposed to a cesarean section. Obviously, if you had a cesarean section and you had a surgery, your recovery would be longer than a vaginal delivery. But generally, for both, the principle is the same. You have to take it step by step, right? Usually, if during the pregnancy you exercise, which is encouraged once you're having a very low risk pregnancy and you don't have any risk factors, usually women that exercise before pregnancy and exercise during pregnancy, after pregnancy as well, they tend to have a better time. Yeah. So it's a step-by-step process, because your body is going through all these changes, and then it's now slowly getting back to where it was prior to pregnancy. So take it step by step. You gradually go. So you may not start off lifting your usual weights and getting your 1 rep max in gym. You wouldn't start there, but you may start with like walking, jogging, before you go into more high intensity workouts and training.
Perfect. And we have another question. Talking about the menstrual issues, how can coaches and trainers modify the periodized training plans that they have put in place that can better support women who might be dealing with some of those menstrual issues?
So the first thing is having a fairly open relationship with your players. So they're willing to come to you with the issue, because a lot of times, just like the breast injuries, women or players aren't comfortable coming forth with it. If you get your gynecologist or your doctor or even your physio, who's ever with you with the team, on the same page or involved, so it's not just one person treating, but it's 2 people collaborating to come up with the best plan for you. You should be able to get a workout plan, because the gynecologist won't really be able to tell you, oh, you should do this, this, and this. They'll be able to deal with your symptoms, while your physio or the medical doctor can say, okay, well, or your sports doctor can say, well, in this instance, after talking to your gynecologist, we could come up with this plan for you. So during this period in time, you're not out completely, but you're still functioning.
Great. So we have 2 more questions that I think we have time to discuss. So birth control is a way to regulate and manage menstrual cycles. Is that something that you would recommend that girls can use to allow for participation? And then if so, at what age would you recommend using that method for regulating?
Birth control, I think, is great. And it can be, as she said, it's not just used for contraception alone. It can be used as treatment for all of these disorders that I spoke about as well. In terms of age and starting it's especially for younger girls, it's a little tricky, because certain countries have different laws in terms of doctors prescribing contraception, even though you may not be using it as contraception to younger girls. So that's where it may get a little tricky, because some countries, they can prescribe without parents' input, and others you can't. So in terms of starting it may be tricky, but once you speak to the gynecologist and they see benefit in starting it and improving symptoms, I don't see any issues with starting.
All right. Perfect. And I'm going to do one more question, and then I want to make sure we have time. So I'll save, if you put a question in and we do not get to it, I'll save it, and we'll try to keep it for the end if we don't get to it right now. But last question that came through is it normal to have lower energy and feel more tired when you're menstruating? And if so, what can females do, whether it's with nutrition, eating or drinking something, but how can they recover that energy during that time when they're menstruating?
So yes, for some women that is very normal. Some women have premenstrual syndrome, where they have changes in mood, they're a lot more tired, and and the things that they would do outside or right before their period, they can't do at that point in time. So yes, that can be normal, depending on the cause of the changes in your mood, because premenstrual syndrome is something actually a little separate, as opposed to women who just may have a different change, and due to the bloated and the symptoms of having a period may just have a different, they may have just a lower mood and the decreased energy. But when it's not something related to premenstrual syndrome, I would say general things. So if you tend to have a lot of pain, I would advise starting with pain meds, and there's certain medications that you can take at the start of the period that can improve that. In terms of nutrition is always good across the board for almost everything. Yeah, so improving your nutrition in terms of your stuff with a lot of foods that are high in iron, especially leading up to your period, would help you a lot. And things like getting rest. I know a lot of people don't get the usual rest that they should, right? Much less around that time, because you have all the different symptoms just that kind of disrupts your normal flow. But rest is always, it always works and it always helps.
Perfect. Thank you, Dalia. So we're gonna transition over to Rue. So Dalia, if you want to stop sharing your screen and pass over to Rue. So again, just to reiterate, if you submitted a question and we didn't quite get to it, I've got it listed here and I won't forget it. And we'll make sure that we get an answer to you or a follow-up for sure afterwards.